Dan, one of the underlying themes of prostate cancer has been maintaining quality of life. There's a lot of patients who are very afraid of getting chemotherapy. I mentioned that figure of 4.8% getting chemotherapy in the hormone-sensitive phase. And even overall, during the entire course of prostate cancer, many patients refuse chemotherapy, and perhaps less than 50% even of all patients get chemotherapy. Is it really a quality of life issue, or is it just a fear factor that we haven't figured out yet?
It's a fear factor. It's a fear factor because of the prevailing wisdom, what people see on television and what they may see from their friends who may receive completely different forms of chemotherapy than what we're administering. I think one of the key things to emphasize is that talking about side effects early, communicating with your doctor, communicating with the nurse practitioner that works with you, is crucial in managing the side effects. If we catch a fever early, if we catch fatigue early, we may be able to do some things to fix those so that the patient can tolerate chemotherapy better. What I've seen over the years is improvements in bone pain, which people don't really capture. Patients' performance status in somebody who is doing poorly to begin with actually can improve. And it's very, very difficult to select that patient out beforehand. But I've seen dramatic improvements in quality of life as time has gone on. So I think the crucial thing is a good relationship between the patient and the physician, carefully explaining what to expect, carefully explaining what side effects to expect, and also emphasizing the positive that you may have an improvement in your quality of life as you're treated.
Has my impression is that docetaxel still is pretty rough on patients.
Yeah.
You know, there's still hair loss, there's still neuropathy. Do you see any difference in the cabazitaxel? What about the dose of cabazitaxel? And what about the issue of the CARD trial where cabazitaxel and the second generation hormones were compared?
Well, as much as I hate to say it, I think cabazitaxel is a better drug than docetaxel. Cabazitaxel is easier to tolerate.
Particularly at the lower dose, I would imagine.
And my patients don't have the same degree of asthenia and fatigue that they do with docetaxel. Also, the neuropathy is an issue. I recently took care of a patient who was a violinist, and we gave him cabazitaxel up front because I was afraid that he was going to lose his sensation in playing his instrument.
And you got the insurance covered.
Well, the insurance covered it. They actually accepted the rationale behind it. So, you know, I think it's a better drug from that standpoint. It's better tolerated than docetaxel is. Some patients, as you're absolutely right, can get pretty beaten up by docetaxel, particularly as you go further and further down the line. I think the CARD trial had some interesting observations. Karim Fazazi has presented some data looking at the quality of life of abiraterone or enzalutamide versus cabazitaxel in that particular study. Didn't see much of a difference between those. So that tells us that the activity of the drug may actually be helping overcome some of the side effects. And you get the same result with Abi or Enza as you do with cabazitaxel. The fatigue with enzalutamide is significant in some patients, and that has to be watched very, very carefully.
And the other drugs that we use that are pretty easily tolerated include CRPC and radium. Would you, is starting with CRPC and radium sort of a first grade look at quality of life? Does this help the patients
it helps
get ready?
Yeah, it helps the patients get ready. And also, I think there are different situations that we can use this in to help the patients, you know, again, maintain a good quality of life. I do see PSA declines with radium. I've seen that. And it's actually very nice when you see that because patients don't expect that at that particular point. And CRPC, we potentially can delay patients going on other treatments afterwards. I've seen patients' PSA sort of flatten out over time, although you may not see declines. The drug does have a role in this disease. So I think that it's a transition into more aggressive treatments later on. You're absolutely right about that. The disappointing thing about the studies with radium is the fact that there was that observation that there was a higher fracture rate when you combine that with abiraterone. We know that adding bone anti-resorptive agents may actually abrogate that particular observation. I would love to try to move radium up front more by combining it with novel anti-androgens. Perhaps the PEACE trial, which is looking at enzalutamide plus radium, will help define that role a little bit better, because I really would like to combine those drugs up front, and secure the bone and secure the other sites of disease with the with the.
Well, I know my practice has been to move radium as early as I can, and it's always a challenge to know whether to give CRPC first or radium first, and the whole integration of second generation AR agents has been disappointing that it didn't show a survival advantage. But you still have to give the drugs because they're still life prolonging. Even though they may not be synergistic in prolonging life, they certainly independently prolong life.
My goal in treating patients is to make sure that they receive every class of drug that we have available to them, whether that be immune therapy, whether that be next generation anti-androgens, whether that be DNA damaging agents like radium and the PARP inhibitors, also the chemotherapeutic agents as well. If we can do that, then I feel that I've accomplished the best possible care for my patients in this situation.
Yeah. And in the long run, their quality of life is maintained. Longer periods of time.
And the quantity of life as well. I was thinking back last night. I was out with Maha and Tia, and Maha Hussein and Tia Hagano, our good friends from SWAG, and we were talking about all the interesting people we've run across in this business. And I think back to that review that I wrote with Alan Yagoda back in 1991 about chemotherapy and prostate cancer, and the survivals only being 12 months at that time. Look how far we've come. 3 years, 4 years that these patients are living, as opposed to where we were at that time. We've made a huge amount of progress in this disease, and again, it's from using these drugs and integrating them properly.
It seems to me that we still need better education. I still have patients who are refusing chemotherapy. I still have patients who aren't getting all the optimal therapies. So we still need to do a better job of educating the patients, but also all medical oncologists.
Medical oncologists, and also embracing populations that may not have had the opportunity to get these treatments before. There was a very, very telling statistic that was published in JCO in a letter a couple of years ago, that the number of African Americans participating in clinical trials is about half of what you would expect from the projected data of the number of patients having castrate-resistant disease. That's our fault. We need to educate patients better. We need to embrace them and embrace people in the community to make sure that they understand what's out there.
Well, also we have data from Dr. Halaby suggesting that docetaxel in African American patients is actually more effective than you would expect. And now we have this preliminary data on CRPC suggesting again that the African American population has an altered immune response and longer benefit to CRPC. So we really need to communicate better with our doctors that treat these patients, but also with the patient populations.
The question is, how do we best do that? And there are a number of different answers to that, because again, it's exposing people to media, to other types of venues. I often say that in an era where we have more tools for communicating with each other, we communicate less than we ever did. And I think that it's, again, incumbent on us to communicate with our patients as well as our colleagues and let them know what's happening.
Thanks, Dan. Appreciate that.